The next presenter is Dr. Abhijit Kumar, HANDIQUE, a new technique of needle-assisted intrascleral haptic fixation in scleral fixated IOL. Over to you, Doctor.
Good morning, everyone. Through this presentation, I'm going to introduce a new technique of needle-assisted intrascleral haptic fixation in SFIOL. I have no financial interest to disclose. Secondary IOL implantation in absence of capsular support has gone through an eventful journey. In 1986, it was Melbourne. We used sutures to fix the IOL in the retropupillary space. The revolution came when the Gabor in 2010 introduced the haptic externalization technique. It was further simplified by Yamane in 2014 and created another revolution. In 2017 and 2018, Bhaskaran and Khatri tried to modify the technique further. But the question always remains, why only a handful of surgeons do SFIOL? In our perception, it may be because of demand of special surgical expertise and dexterity. The most procedures don't yield consistent result. And some of the complications like IOL issues and consequences faced by many surgeons. In our new technique, we try to achieve the surgical consistency to make the procedure easy to adopt by most of the surgeons and to achieve tilt-free stable IOL fixation. Let's see the technique through this video. Continuous infusion is a must in the closed chamber technique. This is a subluxated IOL, and we had to explain this. And the particular in this technique is that creating a curved needle using a 26.5 gauge needle using a wire contourer or a needle holder. The first haptic is out using a straight needle. This special needle is used to create a needle track to which the haptic is fed. When the needle is withdrawn, the haptic will be fixed in the scleral tunnel. Then now this haptic is firmly secured, which has no chance to go back when we will be externalizing the other haptic. We can see the use of this special curved needle once again. The curved needle is used to create a needle track. To the bore of the needle, the haptic is fed, needle is withdrawn, and the haptic will be again fixed into the needle track. The beauty of this technique is that we have chance to readjust the IOL, the fine tuning, which is not possible in techniques like tip melting technique. So we can compare the needle track fixation. Even Yamane and Gabor has also, not Yamane, actually Gabor and Khatri, they use a needle track technique. Gabor, he uses a forceps, Khatri uses a straight needle. But in our technique, we used a curved needle because of which it can negate the orbital rim and we can choose any meridian for IOL orientation. The pilot study in 22 eyes, by the time we submitted this presentation, we faced mostly the cases with cataract surgery complications. In post-op, we faced high intraocular pressure and some intravitreal hemorrhage, which could be manageable. But the beauty is that there was no IOL decentration and demonstrable IOL tilt. The perceived advantages are the firm fixation could be achieved. We could avoid the empty needle track difficulty. And accidental full thickness scale perforation is almost nil because of the rudder effect of the needle design. Predictable needle tip emergence negates the orbital rim, so we can choose any meridian if we wish to. Easy haptic fading in the needle bore because needle bore is away from the sclera, and fixation is one haptic prior to another. The slippage is almost nil, and no nebulousable IOL till in the pilot study. So in the conclusion, curved 26.5 gauge needle assisted needle track implantation technique appeared to be easy to adopt, had good consistency and no demonstrable IOL till in any of the cases till now. There's a YouTube link for more videos in this technique. Thank you.
You've been doing this technique for quite some time, and I think anybody else has not used that curve. How easy is it to maneuver this curved needle?
It's like the curved needle we use in ECC cases. It's quite easy.
It is easy to use this curved needle intraocularly. Also, it's easy to use it.
Yeah, it's because it's mounted on a syringe and we can use it easily.
To engage the haptic.
Yeah. And to engage the haptic, I have used a microforceps, but any other forceps can be used, even a McPherson.
What
also.
was the purpose of this? What do you want? Did you want to make it simpler for a starting surgeon, a beginning surgeon, or is it more complicated for a surgeon who's starting? Does it require a more experienced surgeon? From what I get, you have done this so that even a more inexperienced surgeon can do this.
Sir,
is that true? Because from your procedure, it didn't look as if it's so easy for a beginner surgeon to do this.
Sir, if I tell about me, I have started with the sutures. I have done even the Yamanes technique, but I was fixed with the Gabors technique because of stability. But in the Gabors technique also, I faced difficulty in most of the cases. But when I improvise it in this way, believe me, I have not faced any issues. And lately, I have done some cases in PK cases also, ECC cases also, where the eye is quite soft.
Okay. Thank you.
Thank you, Doctor.